In the late 1980s, Nepal's economy was centered on subsistence agriculture. Its geography is landlocked and rugged, and at the time, the state's institutional capacity to deliver services was limited. To address economic instability, the government initiated structural adjustment programs with the International Monetary Fund. These agreements provided balance of payments support in exchange for specific policy changes. This was the era of the Washington Consensus. The policy mandate focused on macroeconomic stabilization through fiscal austerity and the compression of public expenditure. These measures set a trajectory for social sector investment that would last for the next 30 years. The 3 decades following these adjustments produced 2 divergent trends. Severe limits on public health spending occurred alongside rapid improvements in national health outcomes. The data shows the scale of this divergence. Infant mortality dropped from 145 deaths per 1,000 down to 25. Yet over that same period, government health expenditure stayed under 1.5% of GDP. These health gains were achieved despite macroeconomic orthodoxy. They were driven by a system that relied heavily on privatized, out-of-pocket healthcare. To see how the state passed financial responsibility to its citizens, we look at the initial structural adjustment period between 1987 and 1990. This table tracks health budget figures during the peak of adjustment. During this window, health's share of total public expenditure was approximately 3.5%. This gap represents the out-of-pocket burden. It accounted for 55 to 70% of all health spending in Nepal. This meant that patients paid directly for their own medical care, from diagnostic tests to everyday basic medications. The fiscal limits did not necessarily improve efficiency. Instead, they transferred the cost of survival to rural and poor populations. While macroeconomic targets were set globally, they were implemented through domestic policy in Nepal's urban centers. Scholarship on these programs identifies 3 ways they alter health systems: direct targeting, indirect effects on labor, and impacts on the social determinants of health. In Nepal, the direct targeting pathway involved the introduction of user fees, framed as a tool for cost recovery. This was paired with the encouragement of private healthcare providers and the devolution of state health posts to NGOs. In the 2000s, policy language shifted toward poverty reduction. The government introduced frameworks intended to prioritize resources for the poor. However, the underlying logic of wage bill caps persisted. Local clinics often remained understaffed because the state could not expand its payroll. These policies changed the landscape of care. They created a system that favored those who could afford private services, while the public core was constrained. Despite these constraints on the public system, national health outcomes improved through 2010. The data confirms this. By 2010, life expectancy rose to 68 years, and infant mortality continued a steady drop. If public spending was frozen, what factors drove these gains? Part of the explanation lies in global immunization campaigns and the general epidemiological transition occurring independently of the state budget. A major economic factor was the increase in remittance inflows from Nepalese workers abroad, which reached roughly 25% of GDP. These remittances, along with foreign aid, effectively bypassed the government. Families used this private income to pay the user fees that the public system required. Nepal's health gains were financed privately through the outward migration of labor. Remittances funded the private care that a public system, operating under strict fiscal restraint, simply could not provide. After 2006, Nepal moved into a post-conflict era and established a new federal political framework. Reforms in 2007 established health as a constitutional right, promising free basic care to all citizens. This legal promise exists alongside the structural reality of the previous era. Out-of-pocket spending still accounts for about 55% of total health expenditure. This vulnerability is significant as Nepal approaches its graduation from least developed country status in 2026. This transition will change the nation's access to foreign aid. Navigating ongoing engagements with the IMF will require managing this gap within a constrained fiscal environment. Nepal's record aligns with broader scholarship on these programs. Without specific safeguards, macroeconomic targets can deprioritize the social investments needed for human development. Addressing this requires enforceable equity safeguards, protected social spending, and the mobilization of domestic resources. Macroeconomic stability provides a foundation, but universal health coverage requires a state system with the fiscal space to invest in its own people.